and get started. Melanie, go ahead and hit start on the recording. Okay, everyone, welcome to our first of our series for FluFIT. We hope that you find this information helpful as you begin to set up your programs. Feel free to make this as interactive as possible. You may use the chat function to place certain questions in the chat box if you have a certain question, and we will also have a Q&A at the end. But it is my pleasure today to introduce to you Dr. Laura Macra. She's a Senior Director at the American Cancer Society. In this role, she provides both strategic and clinical leadership to various cancer control programs, including community initiative programs aimed at increasing cancer screening and reducing cancer-related disparities in underserved populations. She also provides clinical and technical expertise for other cancer control activities, including colorectal cancer, skin cancer, and liver cancer. Prior to joining ACS, Dr. Macra served as Senior Clinical Advisory for the Office of Quality Improvement at HRSA. In her role at HRSA, she provided clinical leadership for the nation's community health center program's quality strategy, which included patient-centered medical home transformation, clinical quality measures, and electronic health record implementation. Prior to joining HRSA, Dr. Macra completed a fellowship in health policy at Georgetown University and the Robert Graham Center in Washington, D.C. She completed her residency in family medicine at the University of Colorado and has experience in a variety of clinical settings, including her own solo practice in community health centers and in integrated delivery health systems. So welcome, Dr. Macra. We're very excited to hear from you. So go ahead and take it away.
Great. Thanks so much. It's great to be with you all today. Thank you for the nice introduction. I think we'll have some chimes, I think, as people join the webinar today, so I'll just try to speak over those for now. If you can just, everybody, mute your lines for now, and we'll open those up at the end for Q&A. If you have questions during the presentation, feel free to put them in the chat pod, and we'll be happy to address those. So I'm glad to be with you today, and thank you for the nice introduction. I am a Senior Director of Cancer Control Intervention here at ACS. I'm a family physician by training, as was mentioned, and I continue to see patients in an underserved setting. So both flu shots and colorectal cancer screening are on my mind a lot. So I'm excited to share with you about a FluFIT program and ways you can implement this in your own setting. So we'll go ahead and get started. Looks like we may have lost our slides for a second. I think we're not seeing the slides on the screen. There they go. Hold on one second, and I'll advance the slides. Okay, looks good. Perfect. Okay. So we have a couple objectives and things that I'm going to discuss as part of the presentation today. First, we're going to look at the importance of colorectal cancer screening and really just review current evidence. And we'll look a little bit at kind of current colorectal cancer screening patterns in different settings, and then take a look at some of the current evidence around stool-based screening tests and patient preference around kinds of colorectal cancer screening. And then we'll spend the last part of the presentation talking about a FluFIT program and an overview of how that would look and how to implement that in your setting. So first, let's take a look at why colorectal cancer screening is important and just review kind of the facts about colorectal cancer. So as you may know, colorectal cancer is the third most common cancer in both men and women in the U.S. We expect 135 new cases and 50,000 deaths in 2017. So that means that over 1.4 million Americans are living with colorectal cancer. And we've seen a steady decline in the incidence and death rates in the last few decades, due in part to increases in colorectal cancer screening. However, we still see that many people are diagnosed with late-stage disease, and where screening can make a big difference. So here's just a graph showing the colorectal cancer mortality decline per decade since the 1970s. So as you can see, colorectal cancer death rates in the U.S. have declined by more than 47% since the mid-1970s. And more than half of this decline has been due to increased population screening. And screening reduces mortality, both by reducing the number of colorectal cancers that occur through the detection and removal of precancerous growths, and second, by detecting cancer at an early stage when treatment is usually much more successful. Oh, sorry, technical difficulty there. Okay, moving on to the next. Just look a little bit closer at this decline in colorectal cancer incidence and mortality. So some of the decline that we see here is due to improvements in treatments and also improvements in increased screening. So as we know, screening can lead to earlier cancer detection, which then leads to improved survival. So that graph there at the bottom just shows that the 5-year survival for localized disease is just about 90%, a little bit more than 90%. But that the 5-year survival really drastically decreases for both regional and then distant disease. I mean, this just really speaks to the importance of broad uptake of colorectal cancer screening. Screening can also lead to removal of precancerous polyps, which ultimately really is cancer prevention. And some studies have estimated that colorectal cancer screening has prevented 550,000 cases of colorectal cancer in the last 3 decades in the U.S. So it's pretty amazing to think about the way that screening for colorectal cancer really has had a huge impact on reducing our incidence and improving mortality. But we have some room to go. So let's look a little bit now at our current screening rates across the country. According to CDC's BRFS or BRFS, I love that acronym. It's a good one to say. So the BRFS data says that 66.3% of eligible U.S. adults were up to date with colorectal cancer screening in 2014. We see lower screening rates among racial and ethnic minorities and in low-income, low-education, and uninsured populations. Screening rates are actually much lower than even the 66% in other underserved settings, such as community health centers, where the national average for colorectal cancer screening was just 38% in 2015. There have been some great increases in screening across community health centers, but that number just speaks to the importance of really addressing the disparities both in screening and prevention for colorectal cancer. So we know that current colorectal cancer screening recommendations include both stool-based testing options, guaiac-based FOBT, or fecal immunochemical test, FIT, or endoscopy, sigmoidoscopy, or colonoscopy. So among primary care clinicians, stool tests, FOBT or FIT, are widely used, but there's lack of knowledge about newer versus older forms of stool tests and some remaining questions about the effectiveness of stool-based testing. In previous studies, colonoscopy has been viewed as the best test when you ask primary care clinicians, but many known barriers are identified, including both patient-related barriers with transportation issues to get to colonoscopy, or time off work, or just desire to not have to go through an invasive test. And prior studies have also shown that screening programs with a focus on colonoscopy are associated with lower screening rates. We also know from prior studies that, unfortunately, sometimes we forget to ask patients what their preference is or don't give them an option. But when we do ask patients their preference, we have different findings. So we're going to look a little closer at some of that data. So when patients are asked about their preference for screening tests, this is what we see. So this trial from 2012 included a total of 997 participants, 58% completing the colorectal cancer screening strategy that they were assigned or chose. However, participants who were assigned colonoscopy completed their screening at a significantly lower rate of 38% compared to participants who were recommended FOBT or given a choice between FOBT or colonoscopy. You can see that there was a 67% completion for patients who were recommended FOBT, And then patients who were given a choice of either FOBT or colonoscopy had a completion rate equal to 69%. I think the point being is that patient preference and choice is an important predictor of screening completion. There's a few other studies to look at when we think about patient preference around stool-based testing versus colonoscopy. So first, there was a study done in 2007 that was a diverse sample of about 300 adults. They got detailed descriptions of both FOBT or colonoscopy, and 53%, so a little more than half, preferred FOBT. And almost half of those felt very strongly about
my own office. Yeah. I'll send you that stuff.
Okay. Just a quick reminder to just mute your lines for us right now, and then we'll open them up for Q&A at the end. Great, thank you. So the next study in 2008 was done at 4 health centers. 200 patients, 212 patients rated different screening options with different attributes. And 37% preferred colonoscopy, and about almost the same, 31% preferred FOBT. And then we look at a bigger sample of around 2,000 patients from the VA who were given brief descriptions of each screening mode, and 37% preferred colonoscopy, while another 29% preferred the FOBT. So what we can see is that many patients prefer stool-based fecal occult blood testing when given a choice between colonoscopy or stool tests. So let's take a closer look now at the different stool tests. I mentioned from past studies that PCP understanding of the newer stool tests may be one of the barriers to uptake of stool tests. So FIT tests are one of those newer stool tests. So the less sensitive guaiac-based tests from before, the lower sensitivity ones, have some misunderstanding. Now we also have high sensitivity guaiac-based FOBT, and we have fecal immunochemical tests, or FIT tests. So FIT tests work a little different than the guaiac-based tests. And FIT tests detect blood by immunoassay. There's an antibody specifically recognizing the globin component of the human hemoglobin. And globin is prone to degradation from the upper GI tract. So FIT are less likely to prevent the false positive results from upper GI bleeding. So all that means is that the FIT tests have a high specificity for human blood and for lower GI bleeding, which is what we would want to know about when we're thinking about precancerous or cancerous polyps. Some types of FIT tests require only one or two specimens, so that's a little bit easier than the 3 specimens with the guaiac-based tests. And studies have shown a higher sensitivity than guaiac-based FOBT. Here's a nice systematic review and meta-analysis of different kinds of FIT that was done in 2014. There were 19 studies included in the analysis, and pooled sensitivity and specificity as well as likelihood ratios were calculated. This next slide shows the results of that study. So this is a look at the pooled sensitivity and specificity for the FIT tests that were included in the paper. So you can see that the pooled sensitivity is 68.45%. and the pooled specificity is 98.5%. So really the conclusion of the meta-analysis was that FIT are moderately sensitive, highly specific, and have high overall diagnostic accuracy for detecting colorectal cancer. Here's one more look at the efficacy of FIT tests. So this modeling study suggests the years of life saved through high-quality stool-based screening program are similar to outcomes with high-quality colonoscopy screening program. So you can see that the colorectal cancer deaths averted for FIT and guaiac-based FOBT were 22, and for colonoscopy, 24. For sigmoidoscopy plus FIT test was 23. So all pretty similar. And the link for the additional information on that study is there too. When we think about stool-based colorectal cancer screening, there are a few important considerations to discuss. So first, stool tests are appropriate only for average risk people. So no family history, no prior history of adenomas, only average risk. We only want to use high-sensitivity guaiac-based testing or FIT, the fecal immunochemical test. Hemocolt 2 and the older, less sensitive guaiac tests should not be used for screening. It's also really important to remember that digital rectal exam done in the office and specimens collected through digital rectal exam are not evidence-based and should not be used for colorectal cancer screening. In the largest study looking at this, 19 of 21 cancers were missed by specimens collected through digital rectal exam. The other important consideration when thinking about a high-quality stool-based testing program is that all positive stool-based tests must be followed up with colonoscopy. This is very important to complete the screening process. Follow-up can be lacking. In some settings, we see less than 75% adherence for that follow-up colonoscopy. And there's lots of barriers to this, and we have some ideas and solutions for that too, but we know there's many barriers to that, but it's very important that any positive stool-based test has a follow-up colonoscopy. It's also important to talk with your patients about the potential cost sharing that may occur if a stool test is used for an initial screen. Some of that's related to just the health insurance benefit structure and the preventive services coverage under the Affordable Care Act. Here's a resource here on the next slide that we put together. This is a one-page document really designed to help educate clinicians and their teams about important elements of colorectal cancer screening using FOBT tests. So this brief provides sort of the evidence and current science about guaiac and immunochemical FOBT, about different test performance and characteristics of high-quality screening programs. And that's available there on that link, and I'll share that at the end as well. So now that we've reminded ourselves why colorectal cancer screening is important, we've thought about the differences in patient preference when given choice about stool-based testing versus colonoscopy. We've looked at a couple issues related to providing high-quality stool-based testing. Now let's move into our discussion about the FluFIT program. So why do FluFIT, and what is it? So FluFIT has become a little bit of a good, easy to say name for a program that would incorporate colorectal cancer screening with annual flu shots. So we know that annual flu shots are an opportunity to reach many people who also need colorectal cancer screening. And the point is that the clinic staff will recommend colorectal cancer screening and provide FIT or FOBT kits to average-risk eligible patients when they get their annual flu shots. Patients then complete the FIT test at home and return the kit to the doctor's office or mail the kit back to the lab for processing, and then results are then communicated back to the patient. We've seen that FluFIT programs are really well accepted by patients, and several studies have shown that FluFIT programs lead to higher colorectal cancer screening rates in a variety of clinical environments, and we'll look at some of those in the next couple of slides. So first, this was, I think, one of the early days in the birthplace of FluFIT or FluFOBT at San Francisco General Hospital. This trial in 2009 was based in a community health center program. And the findings are really quite impressive and show an increase of 29.8 percentage points for completion of colorectal cancer screening after flu shot season for those patients who received flu shots plus an FOBT kit. There was also a small increase in patients in the control arm, that's the flu shot only arm, but not to the level of what was seen for patients who were provided FIT kits at the time of a flu shot. So you can see that the baseline screening rate was 54.5% in the intervention arm, or the arm where patients received flu shot plus FOBT kits. After flu shot season, that number of up-to-date screenings rose to 84.3%. So pretty impressive. So following that study, another study was done in a bigger integrated delivery system at Kaiser Permanente in California. And this table is from this paper from 2013 that shows the number and proportion of eligible patients who completed colorectal cancer screening tests within 90 days of their flu shot compared to the control group. So you can see that 11.7% in the control arm, that's the flu shot only arm, completed FITs, and 26.9% in the intervention arm, so FIT plus the flu shot, completed their FIT test. So that represents an increase of 15.2% in those who received flu shot plus FIT. Overall, 15.2% in the control arm and 29.7% in the intervention arm completed any colorectal cancer screening test in the 90 days after being vaccinated, which represents an increase of 14.5% over the control group. So again, pretty impressive screening rate increases for a pretty simple intervention and a way to reach a big population of people. So why try this? So many sites use FluFIT as a way to begin the process of incorporating preventive counseling, including colorectal cancer screening, into routine practice outside of flu season. Like we talked about, the same guidelines apply. So like flu shots, colorectal cancer screening with a stool test is repeated every year on an annual basis. And annual testing is really necessary to be effective and evidence-based when doing stool-based testing. So FluFIT is just opportunistic. The same guidelines apply. We repeat yearly stool tests along with yearly flu shots. Flu shots and colorectal cancer screening are important to populations over age 50, so it is a nice fit and goes well together. So now we're going to talk a little bit about how to set up a FluFIT program. So where do you go from here? We're going to talk a little bit about an implementation plan, and then there's some resources I'll share at the end, and all of this is available on the web in both kind of a toolkit format and then an interactive website format. So there's lots of great information to be used down the road as you think about this. So let's get started with what's going to be most important. So the first step, maybe most important, is to assemble your team. So you want to select a champion to help coordinate the efforts. This doesn't have to be a physician. A physician certainly can be great champions, but doesn't have to be a physician. It could be a nurse or another member of the care team. Then you'll want to select team members and the staffing levels, remembering that you want to include an interdisciplinary team that includes both clinical expertise as well as some data expertise to help tell the story of the impact of your program, and then, of course, the important pieces around patient education and patient preferences and how to reach your community. So after you have identified your team, then, of course, you want to train the team. So here's a few big picture topics that are important to incorporate into your training. So you want to, of course, talk about the importance of flu shots, why we give them, what's important for patients of both flu shots and colorectal cancer screening. You want to train your team about how you're going to organize your workflow. What's it going to look like? How are patients going to get their FIT test along with their flu shot? How does that work in your setting? And you'll want to figure out how to assess patient eligibility and make sure your team is trained on that, like who's eligible for colorectal cancer screening at the time of flu shot, and then most importantly, too, who is not eligible. We'll talk about that a little bit later. And you also want to train your team around patient education and how to talk to patients about completing their FIT test and what to do, what the test is about, how they complete it, how they return the result, and all of that. And then, of course, develop a system of test tracking and follow-up, both for all patients who complete their test and have a negative result, and then also patients who complete the test and have a positive result and will need follow-up colonoscopy. So after you've assembled your team, you've found a champion, you have appropriate staffing on the team, you're starting to think about training your team, then you're going to want to think about the time and location for your program and advertise that FIT FOBT will be offered with your flu shots this year. So you're going to decide when you want to start, where to hold the program, and then the various places you'd want to advertise. And then you'll design a patient flow and management plan after that with attention to assessing patient eligibility. And then there's some recommendation that it usually works best to offer the FIT or FOBT kit before the flu shot. That just seems to help with the flow of patients through your flu shot clinics. So many times, in my experience, and I'm sure many of your experiences, flu shot clinic hours get very busy. And so being able to talk to patients as they're waiting and give them information about colorectal cancer screening and offer them the stool test can be a good use of their wait time before their flu shot. So who is eligible to participate and get a FIT kit or an FOBT kit during the program? So you want to make sure the patient is 50 years or older, that they have not had a colonoscopy in the last 10 years, and they have not had an FOBT or FIT test in the past year, and that they're not at increased risk for colon cancer. So that last point about not at increased risk is especially important, because remember, stool-based testing programs are indicated for average risk populations only. So who should not be offered a FIT or FOBT kit? So you'll want to train your team on who should be offered the FIT kit and then who should not be. So any patient who meets this criteria should not be offered a FIT or FOBT kit. So patients who are less than age 50, any patients who's already had a colonoscopy in the last 10 years and would be considered up to date on screening, any patient who's had a stool-based test for colon cancer screening in the past year, so again, already up to date. And then these last two categories are patients who would be higher risk. So anybody with a personal history of Crohn's disease or ulcerative colitis, anybody with a personal history of polyps or cancer, any patient who has a family history of polyps or cancer in a family member younger than age 60, and then any patient who has symptoms, so rectal bleeding, blood in the stool, or any other symptoms that would be not average risk and would put them in the higher risk category. So any patients who have those last group of risk factors should be directed to a clinician for appropriate screening recommendations. So your team is assembled and trained. You've developed your workflows, including screening eligibility. You're working on a time and a place to hold your program. And now you need to develop some systems to track and monitor the FIT kits that are given to your patients. So you want to be sure to develop systems that support follow-up for patients who receive a FIT kit. So make sure patients get clear instructions, that they have a return envelope for their kits, including the address to mail it back to, maybe pre-addressed. Reminder phone calls and postcards are a good idea to develop before your program starts. And then, of course, the follow-up care and the importance of everybody with a positive stool test having a colonoscopy. Patients will have questions about, I'm using it for my flu shot. Why are you talking to me about colorectal cancer screening? So you can use that time to educate your patients about the importance of colorectal cancer screening and the option of a stool-based test with FIT or FOBT versus colonoscopy. And it's important to help the patients understand that how to complete the test and then how to return the test and where it should be mailed to. Should it be mailed back to the clinic? Should it be mailed directly to the lab? How is that going to work in your setting? And that the patient understands those instructions. The other important part of this sort of tracking and monitoring is telephone or postcard reminders and how important those are. If the patient hasn't returned the kit within 14 days, a phone call or a postcard reminder is really effective. Some studies show that these kind of reminders can double your return rates, so you'll get a lot out of that investment. So all of the information we just discussed, like I said, is available in our ACS and National Colorectal Cancer Roundtable FluFIT implementation guide that's available at this web address. We're working on an updated version that will be out later this summer that will have just the updates related to the updates from the U.S. Preventive Services Task Force recommendations from last fall, and then a few updates around different quality reporting programs that include colorectal cancer screening as part of them, like MIPS, for example, the new quality payment program for physicians at Medicare. So that'll be out later this summer, available at the same web address. The implementation guide includes a lot of different parts that we've discussed, along with more in-depth information, including background information like we talked about around colorectal cancer and FluFIT or FluFOBT programs, algorithms for patient eligibility criteria and workflow ideas, colorectal cancer screening recommendations, patient education materials are in the implementation guide, more in-depth guidance on how to set up your program, and then examples for both advertising tools as well as tracking and monitoring tools are all included. And along with the ACS resources, there's also this FluFIT website that was developed by the University of California, San Francisco, the birthplace of FluFIT. And this is really a comprehensive web-based resource available at flufit.org. This website includes the CDC flu vaccine recommendations and guidelines, different information on commonly used FOBT and FIT brands, and then patient instructions both in various languages as well as patient instructions to address lower literacy levels and some patient videos that are really helpful. And there's also sample tracking results, sheets, postcard reminders, and telephone reminder scripts. And lastly, just wanted to highlight and mention a few other resources available through our ACS website at cancer.org. There are sample screening algorithms and policies through the cancer.org MD, or you can access those through your ACS staff partner in your community. You can find a number of resources to help guide your practice on the websites, including a toolkit at MD and other resources to help increase colorectal cancer screening rates in addition to FluFIT programs. Our guidelines are available there, other presentations to share with staff and other team members. There's also free continuing medical education credits available for physicians, NPs, and PAs, and then access to our peer-reviewed journals through this website as well. So with that, I will close and hand it back to our moderators for question and answer. Thank you.
Thank you. That was awesome. Anybody have any particular questions? Please either just unmute your phone lines and speak up, or feel free to put them in chat. One of the questions that I have in the meantime while you're formulating your questions is if everyone that has already completed a FluFIT series in the past that has some experience, would you mind just going up to the little person on the top of your screen and hit raise your hand? Because it would be nice to find those people in our audience that have some experience with this. Okay, the other thing that I wanted to highlight is that we do have an additional series available of our classes, and I'm struggling trying to find my share my screen. Aha, thank you. So here is our upcoming series. This is our first one of 4. We go through more specifics on how to assemble the team, and that registration link will be sent out after this series, as well as developing the FluFIT workflow, and then systems to support patient follow-up. Mountain Pacific Quality Health will have collateral learning materials and postcards that you can send out to your patients. So we'll try to make this as simple as possible for your clinic. There'll be an ordering process online on our website, and then of course you can review any of these webinars for team education with your clinics. So those are some resources that are available. Any further questions? The other thing that I would request that you guys would do, if you wouldn't mind, in the chat box, if you have more than one person on the phone line, if you can enter that information in the chat, that would be very helpful. Oh, and Emily just reminded me that we do have office hours that will also be promoted. These are times that will be a little bit smaller of a group that you can ask specific questions and learn from your peers about different techniques that they have tried to do to either do in promotion, in education of the staff, as well as encouraging follow-up for patients and what kinds of tracking tools, et cetera, they have used. So feel free to share with others. We all learn faster, better, smarter when we all share together. So that is helpful. So we will send out the link for the TA after this meeting as well. So you can put that on your calendar if you'd like to participate in that. We'll see how these things work. Anybody else on the phone have any other questions?
This is Sonja from Kodiak calling. I am wondering which FIT test works best. I've heard of some where you only need one specimen, some where you need 2 specimens. And I guess I would like to know, if we're going to do it, which is the best test to use?
Yeah, that is a great question, Sonja. This is Dr. Macra. So you're right. There's different sensitivities and specificities, and really it's a hard question to answer. So I'm not trying to avoid it, but it's a little bit of a hard question to answer. The best test is both one that is affordable to your center and that makes sense. They all have pretty similar sensitivities and specificities. The one sample test can be a little bit easier, especially I'm guessing in your setting in Alaska, there's just probably more transportation barriers than I probably even imagine from where I live. So that would be sort of my recommendation. That the clinician's reference that is in the slides that has information about different FIT tests in it, so you could share that with your clinical leadership so you can all make a decision together.
Thank you.
So another question for you along those same lines, is there specialized lab equipment that needs to be vetted by the lab systems manager, or is it fairly simplistic?
That's a great question also. So some of the tests are CLIA waived, so that's pretty simple. The tests, and they all have their own quality controls as part of the manufacturer instructions. Some of the tests will need more kind of lab oversight if you're doing it in the office. Some settings will choose to send their stool samples to a lab, like a LabCorp or Quest kind of facility, and they'll process the test for you there.
Another thing that is also very handy is that in order to increase compliance with the return of the sample is to ensure that that postage is fully paid. If you can do, fully paid postage, that decreases another barrier for people actually getting it in the mail in a timely manner.
Yeah, that's a great point. That makes a big difference.
Does anybody have any questions specifically around how to promote physician champions for the program? Is that something that you would consider a barrier in your organization, or are you on the phone call because your physicians have said that, yes, we want to do this? Any comments or feedback about that? And if you're shy, you can always type. Okay, well, I don't see that we have other questions right now on the phone or in our chat box. So everyone stay tuned to additional information on our series, and don't hesitate to reach out to us about what you will need specifically to have the most successful FluFIT program that you've ever had before. So we are here to support you with technical assistance, finding answers to your questions, as well as just providing you models of care that seem to work well, and we can learn from all of the different settings across our 4 states. So thank you everyone for attending. There will be a short evaluation of the webinar today that we would encourage you to complete and add any additional information that you wish. And I guess we will give you a couple of minutes back in your day. So thank you all.